Now let me present the next presenter, who's Mr. Zanga. And Mr. Zanga is a lecturer at the University of Zimbabwe. He's also a specialist ultrasonographer and also has special interest in fetal medicine. So you'll be taking us through obstetric Dopplers, how to, and clinical application other than FGR. Mr. Zanga. As he comes, when blood meets resistance, growth falters, but Doppler allows us to interpret the dialogue going on there.
Okay. It's just confused me. All right. Thank you, Mr. Kombola. Mr. Kombola is, can you believe he's my student? Now we are colleagues. All right. So I have a very easy task of taking you through that. I'll try to breeze through it. It's like the foundation of most of the presentations which have been done, some which will be done. So I'll just be explaining a few things there. All right. So, all right. So that's my presentation outline, which encompasses the types of Dopplers available, how to perform the Dopplers, clinical applications of obstetric Dopplers. All right. So antenatal monitoring of high-risk pregnancies with the aim of preventing perinatal death and or handicap is one of the vital tools in which Dopplers can be used in the fetal growth assessment. So I've got the various types of Dopplers which I'll go through. All right, so fetal growth assessment, which the colleague who has just presented before told us about the biometry. So, yeah, this thing is very sensitive. All right, so the Dopplers also have nomograms. So there is nothing like a PI of, let's say for the umbilical of 1.30 is abnormal. It has to be related to the gestational age. So they also have nomograms. You can see here, we've got the PI values. Then here, we've got the gestational age. So you can see one value can be abnormal at a certain gestational age and be normal at another gestational age. So they have nomograms. All right. So I will start with the uterine artery Doppler. The uterine arteries, when the first trimester was being done, it was demonstrated it can be done transabdominally or through the transvaginal route. So the uterine artery, when you're using the transvaginal route, you have to identify the cervix at the level of the internal os. That's where you identify the uterine artery. And you have to use a gate size of 2 millimeters. So these gate sizes are very important when it comes to Doppler. You mustn't use, let's say, 1 millimeter sampling volume when you are doing the uterine artery, and probably use 2 millimeters when you are doing the ductus venosus. So you have to pay particular attention to the sampling volume, which is the gate. The gate is the equal sign which you get when you activate pulsed wave Doppler. So the other thing you have to ensure is that the angle of insonation is less than 30 degrees. If possible, 0 degrees, whereby the beam is parallel to the vessel is the ideal. And this top one, that's a normal waveform of the uterine artery. So for you, even before you measure, just by eyeballing, you should be knowing that this is a low resistance vessel when it's normal. So what happens? The peak systolic and the end diastolic ideally should be close to each other. There should be a high velocity in the diastolic flow when it is normal. Then you can see here, there's now, they are now like skyscrapers, whereby there's now a big distinction between the top and the peak systolic and the diastolic. So the PI invariably increases. But remember again, it has to be linked to the gestational age. All right. So that's the uterine artery Doppler. I move on to the umbilical artery Doppler, supposed to be performed on a free loop of the umbilical cord. So what do we mean on a free loop? Like it should be floating in the amniotic fluid so that it doesn't have interference of compression from the fetal parts or any other thing. So it should be a free loop. You identify a vertical section of the umbilical artery so that your beam will be parallel to the vessel. So you find in some textbooks, they say it's impossible to achieve 0 degrees, but in obstetric Dopplers, it's actually possible. So you identify a vertical section of the free loop, your gauge size, 2 millimeters, then you activate the color Doppler, then the pulsed wave Doppler, and it's characterized by high velocity diastolic flow. So this one is more like a mirror image of the uteri. They should all be ideally low resistance. So the umbilical artery should also have a low PI when it's normal. And another thing which I need to just put to your attention is that there's nothing like too low resistance when you're talking about the umbilical. Like the lower it is, the better. Okay, so you don't say low PI when you are talking about, because that's the normal. All right. Then one of the common pitfalls, before I go to the pitfalls, ideally you should sample both, because remember there are 2 umbilical arteries. You should sample both. Probably if you get high resistance in one, try to sample the other one. Because sometimes you can have different resistance in the 2 arteries. All right, then one of the pitfalls is if you sample a compressed part of the cord, you can get a false abnormal umbilical artery Doppler result. All right, so I move on, or these are some images of 2 umbilical Dopplers. On the left side of the screen, you can see it's low resistance, low PI, which is what we want, that's normal. Then here, usually how it deteriorates, it starts with decreasing the EDF and increasing the PI. Then when it continues to deteriorate, you end up having absence of flow during diastole. Then when it becomes even more deteriorated, you end up having reversal of flow during diastole. So that's an example of reversed flow in the diastole. All right. I move on to this one is not really commonly done, but it's a very important Doppler, the middle-cerebral artery Doppler. So the MCA is a branch of the circle of Willis at the base of the skull. So how do I identify it? From the plane of the head circumference, usually you have to tilt the face upwards so that you make the greater wing of the sphenoid bone parallel to the beam. As you can see here, you can see that the anterior part of the face is lifted. It's not like when we are doing the head circumference BPD, you can see it's lifted. It makes it easier for you to visualize the greater wing of the sphenoid bone, where you will find the MCA running through. You employ your color flow Doppler, identify it. Then you place your sampling gate of 2 millimeters within the middle portion of the middle third of the middle cerebral artery, with your angle of insonation ideally 0 degrees or less than 30. And one of the common pitfalls which happens is you might have reversal of diastole when you are sampling your MCA. And usually it's as a result, if you put too much pressure on the skull, like on the fetal skull, you might actually have the reversed flow. But it's usually not of much concern. So if you release the pressure, you'll find that it will normalize. All right, so I've got 2 images. I think earlier on, it was talked about asphyxia. So the MCA is an important vessel to actually evaluate if the fetus is getting enough oxygen. So when the fetus is happy with the oxygen situation, you'll be having these skyscrapers. So the MCA is more like the opposite of the umbilical. The umbilical, when it's normal, it's a low resistance vessel. The MCA is actually the opposite. It's a high resistance vessel when it's normal. So when it becomes abnormal, you've got the umbilicalization of the MCA, whereby it now starts to have the peak systolic and the end diastolic close to each other. We call that redistribution, whereby the fetus will be trying to spare the brain. So it starts rerouting the blood first to supply the brain, to preserve the brain by reducing the resistance. Then it's one of the signs actually that of hypoxia. Ductus venosus, I think it was mentioned earlier on, it plays important roles both in the first trimester and also in the second and third trimesters. So it can be imaged in either a sagittal view or a transverse view. How do you identify it? The ductus is one of the shunts. It's a continuation or a bypass from the umbilical vein. As it becomes the portal vein, it continues as that conical vessel, which has an aliasing effect. Like if you put color Doppler, it has an orangish, reddish appearance. So it plays an important role in the assessment. It's one of the additional markers for first trimester aneuploidy screening, but it also informs us about the functioning of the heart. If there are possible heart defects, you can pick it by an abnormal waveform of the ductus venosus. So for the ductus venosus, you use a small gate less than 1. So from 0.5, because it's a tiny vessel, from 0.5 millimeters to 1 millimeter. That's the gate which you use with the angle of insonation less than 30 degrees. If possible to achieve 0 degrees, the better. All right, one of the common pitfalls which have to do with the ductus venosus is probably reversal flow, whereby if you're not very careful and you sample the IVC, you might actually report that there is absent or reversed a wave in the ductus venosus. So these are just some images to show this one. That's a transverse view of the ductus venosus. That's a sagittal view of the ductus venosus, or giving us the molar tooth appearance of the ductus venosus. This is normal. It's starting to become abnormal. Here you can see absence. Then you can see reversal is deteriorating, and probably the fetus will be on the verge of cardiac failure there. All right, so these are just some images of the ductus venosus. I think it was demonstrated in the first trimester, whereby the image should be zoomed, occupying much of the screen. And that's a normal waveform here with a positive A wave. Then here you can see there is actually reversal of flow in the A wave. So in the first trimester, usually if you have such a waveform, and probably all the aneuploid screening tests have been done and they are normal, this is a candidate to book for a fetal echo, a detailed echo, for thorough examination of the heart. Then this is another use of Dopplers outside the fetal growth restriction, whereby you check for tracker speed regurgitation. I think it was also demonstrated, and with a gate of 2 to 3, and with that nomenclature there, whereby that's how you arrange the waveform, and you get that's a normal. Then this is abnormal. You can see that we've got these jets. Usually the upper limit is, it shouldn't exceed 60. So when you see here, you can see these spikes are just showing that there is tracker speed regurgitation. And if the aneuploid has been done and it's normal, this is another candidate for a detailed fetal echocardiography. So I'll just summarize the clinical applications of Dopplers outside fetal growth restriction, which will be talked about by the presenter who will talk after me. All right, so in the first trimester, Dopplers play an important role in screening for preeclampsia. There is a presentation in line which will delve into this in greater detail. You saw the first trimester demonstration live session that it showed that the uterine arteries can be sampled. And I think one of the major points is it's not done in isolation. It has to be combined with other factors for you to calculate the risk of preeclampsia. So it plays an important role in screening. If the woman screens high risk, then there is probably need for preventative medication like aspirin, so as to prevent the development of preeclampsia. Then also screening for fetal growth restriction. Usually these two are linked. Then the aneuploidy as additional markers. Then the cardiac defects, which I just talked about. Then in prenatal diagnosis, Dopplers also play an important role, like the MCA. We talked about the oxygenation, but it also plays an important role in detecting fetal anemia. I think there are some presentations which should be done to talk about fetal anemia, how it can be diagnosed intrauterine using the Dopplers. So you actually check what's called the peak systolic velocity, which shouldn't exceed 1.5 multiples of median. So when it exceeds 1.5 multiples of median, then there is a chance that the baby could be suffering from fetal anemia. Fetal growth restriction to be delved in greater detail in the next presentation. Triple TS and TEPS, it's also taking advantage of the ductus venosus in the umbilical Doppler to actually diagnose this condition. I think it will also be discussed in greater detail during the multiple pregnancy. Then there is also need for surveillance of fetal anemia to see if there is improvement which is taking place. I think there's a case which we are going to hear whereby there was some intrauterine transfusion. So you can use the Doppler for surveillance to see if there is improvement and probably if there is need to redo the transfusion. All right, so I think I've touched on everything.